Vital signs are the most basic, non-invasive measurements of essential physiological functions. They serve as the primary screening tool for assessing illness severity and physiological stability. Critically, abnormalities in vital signs often provide the earliest warning of clinical deterioration, guiding the need for urgent investigation and intervention. We begin with the core set of measurements, known as the quintet of assessment. The 5 standard vital signs are body temperature, heart rate, respiratory rate, blood pressure, and oxygen saturation. In modern practice, a 6th vital sign is universally recognized: pain assessment, which is now considered a standard component of the initial evaluation. First, let us examine body temperature, focusing on the physiology and pathophysiology of fever and hypothermia. The normal range is approximately 36.5 to 37.5 degrees Celsius, or 97.7 to 99.5 degrees Fahrenheit. It is important to note that this range varies slightly depending on the measurement site, such as oral, tympanic, temporal, or rectal. Fever, or pyrexia, is defined as a controlled elevation in core body temperature, typically above 38.0 degrees Celsius or 100.4 degrees Fahrenheit. Its pathogenesis involves cytokine-mediated resetting of the hypothalamic thermostat in the brain. Clinically, a fever indicates an underlying infectious, inflammatory, neoplastic, or autoimmune process. The pattern of the fever, whether it is continuous, intermittent, or remittent, can offer valuable diagnostic clues. It is distinct from hyperthermia, which is an uncontrolled temperature elevation, as seen in heat stroke or malignant hyperthermia due to a complete failure of the body's thermoregulation. On the opposite end of the spectrum is hypothermia, defined as a core temperature below 35.0 degrees Celsius or 95.0 degrees Fahrenheit. Causes include prolonged environmental exposure, severe sepsis, metabolic disorders like myxedema coma, and the effects of certain drugs. Hypothermia is clinically significant because it leads to progressive cardiac instability, coagulopathy, and is a notably poor prognostic sign when it occurs in the context of sepsis. Next, we decode heart rate, commonly assessed as the pulse. The normal resting range is 60 to 100 beats per minute. A comprehensive assessment evaluates not just the rate, but also the rhythm, whether it is regular or irregular, the pulse volume, and symmetry between limbs. Tachycardia is a heart rate greater than 100 beats per minute. The most common form is sinus tachycardia, which is a physiological response to stressors like fever, pain, anxiety, hypovolemia, anemia, heart failure, or hyperthyroidism. Pathological tachycardias, such as atrial fibrillation, supraventricular tachycardia, or ventricular tachycardia, require an electrocardiogram for definitive diagnosis. Bradycardia is a heart rate less than 60 beats per minute. It can be physiological, as seen in well-trained athletes or during sleep. Pathological causes include sinus node dysfunction, heart block, hypothyroidism, hypothermia, elevated intracranial pressure, and medication effects from drugs like beta blockers or digoxin. The respiratory rate is often called the most sensitive yet neglected vital sign. The normal adult range is 12 to 20 breaths per minute. Tachypnea, a rate greater than 20 breaths per minute, is a highly sensitive marker of physiological stress. Causes are numerous and include hypoxemia, metabolic or respiratory acidosis, pain, anxiety, primary pulmonary disease like pneumonia or pulmonary embolism, sepsis, and congestive heart failure. Bradypnea, a rate below 12 breaths per minute, often indicates central nervous system depression. Causes include opioid or sedative overdose, metabolic alkalosis, brainstem injury, and severe hypothyroidism. Also note abnormal breathing patterns. Cheney-Stokes respiration, with its crescendo-decrescendo pattern, is associated with heart failure or stroke. Kussmaul breathing, which is deep and labored, signals metabolic acidosis. And Biot respiration, with irregular clusters, suggests brain injury. Blood pressure interpretation requires understanding both hypertension and hypotension. Blood pressure consists of the systolic pressure, representing ventricular contraction, the diastolic pressure, representing ventricular filling, and the calculated mean arterial pressure, which reflects the average perfusion pressure driving blood to organs. Hypertension is defined as a sustained blood pressure at or above 130 over 80 millimeters of mercury. It is staged as elevated, stage 1, and stage 2. It can be primary or essential hypertension or secondary to causes like renal artery stenosis or endocrine disorders. A critical distinction is between hypertensive urgency, which is severe elevation without acute end organ damage, and hypertensive emergency, which involves active damage such as encephalopathy, retinal hemorrhage, or pulmonary edema. Hypotension is typically defined as a systolic blood pressure below 90 millimeters of mercury or a drop of more than 40 millimeters of mercury from a patient's baseline. It is a key sign of shock, which is categorized into types: hypovolemic, cardiogenic, distributive, such as septic or anaphylactic shock, and obstructive. The clinical significance of hypotension is inadequate end organ perfusion. Therefore, you must always assess the patient's mentation, urine output, and skin perfusion via capillary refill time when hypotension is present. Oxygen saturation, measured by pulse oximetry, has become a cornerstone of monitoring. The normal range is 95% or higher on room air. The principle relies on measuring arterial hemoglobin oxygen saturation through differential light absorption. However, there are critical limitations and pitfalls. False normal readings can occur in carbon monoxide poisoning due to carboxyhemoglobin and in methemoglobinemia. Technical errors are common with poor peripheral perfusion, hypotension, hypothermia, motion artifact, dark skin pigmentation, and even nail polish. A phenomenon known as silent hypoxia was notably observed in severe COVID-19 pneumonia, where patients maintained deceptively normal oxygen saturation levels until experiencing profound respiratory decompensation. In clinical use, oxygen saturation guides oxygen therapy, with a general target of maintaining saturation at or above 92 to 94% in most acute illnesses while avoiding unnecessary hyperoxia. Pain is formally recognized as the fifth vital sign. Assessment should use a validated scale, such as the 0 to 10 numeric rating scale, or the Wong-Baker Faces scale for children or those with communication difficulties. The clinical significance is paramount. Uncontrolled pain indicates ongoing tissue injury, exacerbates the body's stress response, and directly hinders recovery. The location, character, and radiation of pain are themselves vital diagnostic clues. Finally, we must adopt an integrated clinical approach, putting all the vital signs together. Never interpret a single vital sign in isolation. Always look at trends over time and synthesize the entire clinical picture. For example, the combination of tachycardia, tachypnea, and fever strongly suggests sepsis or pneumonia. The triad of bradycardia, hypotension, and altered mentation points toward possibilities like opioid overdose or raised intracranial pressure. To formalize this synthesis, many healthcare systems use early warning scores, such as the Modified Early Warning Score or National Early Warning Score. These systems assign points to deviations in each vital sign, generating a composite risk score that prompts earlier clinical review for deteriorating patients, ensuring timely intervention. Thank you for watching. Don't forget to like, share, and subscribe. See you in the next one.